Address Racism in Nursing, a multi-organizational collaborative of leading nursing organizations examining the issue of racism within nursing and motivating all nurses to confront systemic racism. This is an 8-part series, and you will earn 1.5 nursing education units for attending today's session. Please stay to the end to complete your evaluation and receive the CNE certificate. Today's topic is addressing anti-Indigenous racism. Before we go over our ground rules, we want to quickly orient you to some of the features of the new iEcho platform that we're using. You can review session materials within your iEcho account in the content section outlined here in green. Presenters will upload their slides and any other relevant materials here for you to use. There is a Conversations tab found within the Discussions tab circled here in yellow. This is meant to be a place where you can engage with other participants in the series. Please note any questions directed to ANA staff or anything that's time sensitive should be sent via email to commissiononracism@ana.org. And if you're also having trouble with any of the features, you can also email us. We have had an overwhelming response to our ECHO series, and consequently, some of the sessions may be larger than we desire. Please bear with us. Although this is a great problem to have, it does mean that you will need to be patient with the volunteer breakout group facilitators and the other participants. Please use the hand raise feature to be recognized. Keep your comments concise, or place your comments in the chat to be part of the discussion, and this will enhance the experience of all the participants. Please pay special attention to our ground rules as we learn and engage with each other today. Note that we will be turning off the chat during the didactic portion of today's session, and you will still be able to message the co-host directly if needed. This is a brave space, so discussing racism and health equity is difficult and uncomfortable, especially for those impacted. Discussions such as these can serve as a trigger. We ask that you maintain respect for everyone joining us today. Please stay on mute until it is your time to speak. Listen intently and respond thoughtfully. Be present. Limit your distractions and multitasking. And take advantage of the virtual features available via Zoom. We encourage you to turn on your cameras when you're speaking, raise your hand, and remember to mute your microphones when others are speaking. Please continue to respect participant privacy. Do not disclose names or other sensitive information. And if you share a scenario that involves a patient, do not use any personal information during the call. Please feel free to directly message us if you have any technical problems. I am now going to turn this presentation over to Dr. Margaret Moss.
Thank you so much for that. Let me just get to my slides quickly, hopefully. And I appreciate the opportunity to speak with you all. I think this is so important, and I'd like to bring my information about Indigenous issues whenever I can in nursing and elsewhere. But I'd like to start with an introduction. Doja Han Ampetu Washte, Margaret Moss Ka Medicine Robe, Imaki Yapie, Damakote, Hoa Pekute, Oyate, Himatanhanye, Hidaja Ed Omawapie. So I just introduced you with my two names. Medicine Robe is my traditional name. It was my great-great-grandmother's name. And then I'm enrolled in Hidatsa of the 3 affiliated tribes of North Dakota, but I'm also equally Dakota out of a Saskatchewan First Nations. And I'd also like to quickly, because I know there's not much time, acknowledge that I'm speaking to you today, just happens to be here in Washington, D.C. on the original territories of the Anacostia. So I'd like to acknowledge that. So this is a picture of the Longhouse at University of British Columbia, where I was director for the previous 5 years. I've been back since this academic term, where we were highly engaged in all these conversations about identity and racism and so forth. So it was a pretty good beginning. So the agenda here today is, as these other ones have been, if you've been going, so I'm going to address the anti-Indigenous racism in healthcare specifically, and then do a case scenario. We'll have the small group discussion and then the large group. So objectives for today, I'm just trying to get the picture out of the way, sorry. Understand how Nursing Canada's intersect with Indigenous thought and ways of knowing in health and healthcare. So these are the kinds of things that I'm listing here that I'd like you to think about when you are coming to the case study. Identify disparities that exist in Indigenous health access, experiences, and outcomes, and describe how anti-Indigenous racism is one path driving these disparities. Use strategies to improve healthcare for Indigenous people, which we'll go over some here. So in nursing, there's two aspects we talk about for nursing, which is the art and science of nursing. And so we'll go into that a little bit. Here is what I call, well, I don't call it, it's the medicine wheel. Some of you are probably very familiar with it. It is representing the parts, the domains of the person, physical, mental, emotional, and spiritual. But in Indian country, it represents so many other things. Again, it could be lifespan. So always start in the east and go clockwise. So this could be infant, teen, adult, and elder. It could be the directions. It could be the seasons and so forth. So it's quite well known as a model out there. And it fits fairly nicely with what we learn when we first learn about nursing with mind, body, and spirit. These tenets are so close. I often say that nursing is the health profession. If any profession could understand Indigenous thought, this would be the profession because we actually talk about these things. Unfortunately, we get busy, get out on the floor, and it's the gallbladder and 238. But if we really did pull out of our pockets what we did learn, we could be very useful with Indigenous patients, and you'll see that coming up. So an elder told me a metaphor about these the four domains, which is think about each one of them as a tire on your car. And if one of them blows, it's going to be a bumpy ride. And unfortunately, in Indian country, and you'll see some stats coming up, often 2, 3, even all 4 tires are blown in all those areas, physical, mental, emotional, and spiritual. So you're just riding on your rims looking for an exit and trying to get to safety. And it's usually as depicted here with, one person trying to figure it out for themselves versus teams helping in some of the other areas. So it's huge disparities all the way around. So there's also differences in the art of healing. So remember, arts and sciences. So there are 4 pretty well-known medicines in Indian country. There's many more than these 4, but these are known as the 4 core ones, which is sage, cedar, sweetgrass, and tobacco, used in so many ceremonies and so many tribes around. Now, they could be used differently. For instance, I just came from the Salish coastal area in Vancouver, and they do not do smudging, which is depicted on the right, which is where you will take sage or one of the other medicines, and you will burn it and take a feather and sort of wash and purify yourself with the smoke. They, however, whoops, let me go back. They, however, do cedar brushing. So it depends on where you are. The medicines are used all over. If you have Indigenous patients, you might want to ask them if they use any of the 4 medicines. Is there any way you can help them with it? Often universities don't teach this. Hospitals don't have policies on this, so they may have to go outside. Some in the West do have actual smudging policies where there's rooms and places and policies that you can do it. Also, the meta paradigm of nursing, the 4 person, nurse, health, and environment. It's one of the only of the health professions, if not the only, I looked this up a while back, but I haven't looked in about 5 years, that had environment as one of the tenets of the profession. And that goes again so well with Indigenous thought that if we ever, again, if you're trying to understand what does this Indigenous person need, how can I help this person? You might bring in the meta paradigm, you might bring in the mind, body, spirit, and try to put it together and understand what is needed in your region. There are 9 cultural groups in America for Indigenous people, and then I usually add urban as a 10th one. Each one has different beliefs, different ways of being, different needs. If you can't know everybody, at least know the tribes in your area and try to figure out what might be useful. So here's some food for thought, and I'm sorry, I'm trying to get this the gallery kind of covering some of my stuff. I'm trying to figure out how to get rid of it. Anyway, sorry. This is just depicting what happened. There was a huge switch in northern North America, which I often talk about, which is both US and Canada. There were estimates that there were 60 million Indigenous people in this area pre-contact, before anybody came. And from when they came, depending on whether you say it's 1600 to 1900, so that's just in 200 or 300 years, there were only 200,000 American Indians on the 1900 census. That is millions and millions and millions of people gone in 300 years. If we were wolves, people would say, oh, they're endangered and oh, now they're protected. No, but we're people and none of that happened. So on the left is depiction of what it used to be pre-contact. Here's American Indians. 1900, it went to this. Just flat, it went to this. And right now we're about here. Conversely, in 1400, this is the Europeans. Then in 1900, see how much more than the flat. And now here's the Europeans. So it completely were erased and wiped out. We're just now coming back with 3 to 9 million, depending on how you count, and I can explain that also. But it was just a huge genocide. And this is a whole nother talk, but there literally was a genocide according to the UN definition of 1948 on what genocide is. So here's a population overview. All I need to have you get from this. Again, this information came from a report I'll tell you a little bit more about in British Columbia. However, it's much of the same information and same ideas happening across both sides of the border. Here you see, so over there, it's First Nations, Métis, and sometimes Inuit. Those are the 3 categories of Indigenous people over there. You can see that the youth, this is what this band is much more than in non-Indigenous. And back then in these reports, they still said Aboriginal. And then when you go to the other end, you can see there's almost no elderly people, just almost none in both Métis and First Nations. Métis are often considered French Canadian mixed with Ojibwe and some others. And then you can see conversely, there are triple the amount of people left at 75 and non-Indigenous, and at least double 65 and over. In the US, I can tell you only 8% of the population of American Indians is 65 and older, and it's almost double for everybody else. And so this is just saying, where do they all go? They had the most youth and then nothing. And people aren't really understanding that. So here, I just want to put up, I have a lot of graphs, so I'm going to say like 3 things out of each one. In this one, I just want you to know that the reddish, at least on my screen, versus the brown are the Indigenous people. And you can see on almost every level, they have all the problems. These are all the problems. Every body aspect and health aspect. So what I like to point out here is just look at asthma. Here is Indigenous people here are non-Indigenous, so that it's that this part here is the disparity. And there's disparities after disparity after disparity, and almost nobody is paying attention to why is that, what's causing it, you know, how can we fix it, etc. Life expectancies is another one, and I can tell you about the US as well. So this, again, this is First Nations, Inuit, Métis, and then non-Indigenous. And again, just as in the US, white females have the highest life expectancy, and then Inuit males have the lowest. And there's these huge disparities. And you might think, oh, well, that's just Canada. I can tell you from my tribe, which is the 3 affiliated tribes of North Dakota, a baby boy born today will have a life expectancy on average of 48, and women 52. This isn't just low for North Dakota, Indian country, or the US. These numbers are the lowest in the Western Hemisphere, lower than Haiti. And in fact, South Dakota numbers for Pine Ridge and Rosebud are even lower than my tribe. And yet, where is all the consternation? Where is everybody going, oh my gosh, that can't be. What can we do about it? Nobody knows. Nobody's really addressing most of it. So what happened is I was in BC at the time, and there was a lot of anti-Indigenous racism just running rampant through healthcare in that province, which is a huge province, and it includes Vancouver and so forth. So there was a game called The Price is Right. So when an Indigenous person came into ER and they were staggering, or even if they weren't, looked a little off or whatever, the people in the ER would try to guess the blood alcohol level without going over. So, you know, try to guess the price without going over. And so stories like this were running all over, and they reached the Minister of Health for British Columbia, and he authorized this investigation and report, which we later named In Plain Sight. So the work was done in June. Several of us, including an Indigenous knowledge keeper, a couple of people were Indigenous. I was the only Indigenous nurse. We released this, and these are how we talked about it. So I'm going to talk a little about, I'm certainly not going through this, don't worry. But we talked to heard from 9,000 people over 185,000 data points. So we could pretty much take what it said. One part that was so important that we came up with was there is no safe harbor for an Indigenous person. From the time they call the paramedics, they don't know how they're going to be reacted at. When they get to the ER, they don't know how the clerk is going to brush them off, how the nurses are going to roll their eyes, you know, how they get left in halls without being rolled through. This again is from 9,000 person input, these things. So whether it's mental health, assisted living, security was a big one, discharge planning, hospital, overall, home care, nurse practitioners, it just, no matter where you are going to be hyper vigilant. And this is if you go at all. Most people don't go. They would rather, unless it gets too terrible, take care of themselves, ignore it, try to piece it together. Can you hear me?
Dr. Moss, sorry, you were muted.
Oh,
I think I hit the wrong button. Sorry about that.
Okay. Anyway, the whole point here is there's no good place. There's no good place. And beyond the scope of the report was, even when you're out of this, there's still no good place, whether it's school, the store, you know, churches, community. So it's just not great all the way around, which is why some of these numbers are so bad. So experiences, and I'm sorry, I'm on my little laptop and I can't see the whole screen, but what's important here is the darker to the left color is never, something like this never happens. In the middle, it's rarely, and in the right, it's always. So even just picking a couple of these, receive poorer care and service than others, And you see that almost halfway across, for non-Indigenous, they say that never happens. And for Indigenous people, it is sometimes or always. Staff act as if you are dishonest, and again, you can see how these bars work. And again, for non-Indigenous, almost never, for 67%. Down here, there's included in care decisions, never or always for non-Indigenous. Anyway, you get the point is that bad things happen a lot, if not always. Good things happen never, and it's just constant. And again, 9,000 people that we talk to. So we talk to Indigenous people. We talk to healthcare workers, Indigenous healthcare workers, non-Indigenous, to get some of these next points. Again, I'll just give a couple. When people come in, they always assume they're drunk or asked about substance abuse. And that has happened even to my kids in America. So I have 4 kids, and they're like, what'd you take? And they're like, nothing. No, really, what'd you take? You know, they just grab onto it and won't take it. They're like, nothing. This happens constantly. I myself had vertigo, just terrible vertigo, to the point I had to go to the hospital in Vancouver, and you know, just couldn't stop spitting and throwing up and whatnot. And so then I was given some, I think it was Valium and some other stuff, you know, to try to calm down systems. So they sent me home with like 5, you know. I'm not sure what that's going to do over a couple of weeks. And so then I called in and said, could I please have some more? And this was maybe a month in. And again, they gave me 5. And they're like, oh, you showed great restraint. I said, no, I did not. No, I didn't need them. I took them when I needed. I didn't show great restraint. So it's just the immediate thing is they assume that we're all on drugs and or drunk. It's happened in every aspect of my family. They never treat it as if cultural traditions are appreciated. That's almost never. Again, I said sometimes here in it's a legal term, Indian country in the US, which is mostly west of the Mississippi, there are hospitals and even universities and so forth that will allow smudging and sweats and this kind of thing. But up there it wasn't, it was rare. Not treated with the same respect and courtesy. Again, you get the point of these. Discrimination to the point carers negatively affected, never feel safe to speak up, not likely to make a complaint, and the complaint process was rarely given to the people in the first place. Always felt like needs were not taken, were taken seriously. Non-Indigenous, it's a long one, and for Indigenous, it is not. The first time I lived in Minneapolis, I was a nursing supervisor part-time during my academic appointment. And I'll never forget that I got a call from somebody down at the front desk saying that there was a couple who was really in distress and needed to talk to the supervisor. I came down and turned the corner, and it was a American Indian couple, and you could have knocked them over with a feather when they saw that the supervisor was also American Indian. I'm sure I was the only one in Minneapolis at the time. And it turned out that the pharmacy had treated them badly, given them broken and mixed pills and told them to go away, kind of a thing. So this stuff happens, again, both sides of the border. Healthcare workers report widespread stereotyping. This is the healthcare workers themselves, Indigenous respondents witnessing interpersonal racism and discrimination, staff not willing to stand up and call out behavior, staff not regularly reminded in many ways that discriminatory behavior can occur. Indigenous people are unrepresented at every level, at all levels. That's also true. Like I said, I think I was probably the only American Indian period at that hospital, which was a university hospital, let alone a supervisor. So anyway, these are, and you can find this report online. Again, I won't spend a lot of time more on this because I see that we're getting down there. So Indigenous respondents, sorry, this thing's in the way. Report personal experiences of racism at work. Colleagues say discriminating or hurtful comments. Colleagues don't understand the differences between Indigenous groups. That's another one. Again, I just told you, did I? I think it's all blur. 574 American Indian tribes, federally recognized tribes recognized by Congress. We're not all the same, and I gave you that example of smudging, sweats in the interior, but on the coast, no, they do other things, and so you really need to know. If you don't know anything else, know your state. Anyway, and this is again referring back to, as it turns out, the medicine wheel. These things impact your emotional health, mental health, self-esteem, spiritual health, and of course, physical outcomes. So we really need to pay attention. I just have a couple of more slides before we break out. So this was originally called the Cartman Trauma Triangle, which is the persecutor, victim, and rescuer. And he was a psychiatrist in 1968. We use some, we've adapted it in healthcare and used some different words. Now, for instance, bystander is rescuer. And so here's some things people should know about being a bystander. Sometimes might be called an ally, or people have different words. So first of all, you should be aware of what's happening around you. So many people don't even know, like, oh, was that bad? Did they say something wrong? You know, oh, you didn't allow them to, or even help them with smudging. You said it was dumb and forget it. And, you know, and then what's your attitude about it? Once you become aware, oh, maybe this is different. Is it good? Is it bad? You know, what do you think about it? What should you think about it? What do you know about it? And then what actions are you going to take? And unfortunately, there's also this thing called bystander effect, which is when there's so many people around, but nobody does anything. So you're like, oh, well, nobody else is doing anything. Maybe they know something I don't know, or, oh, I don't want to be the first. What are they going to think about that? Or, you know, maybe we can get to them later, or, you know, so if nobody does anything, it's more likely that an individual also won't do anything, and then you're stuck in that triangle. So should you intervene? Yes, you should. And the goal is to prevent current continuance and future harm. And how do you intervene? There are many different ways this could happen. You could go to the person themselves and say, you know, did you need help? Or what's going on here, you know, depending on your level as well. If we're talking about nursing in hospital situations, for example, you know, there's all the levels. Or you could go to a supervisor, or you could, which is what I did. I called the chief pharmacy person and said, you know, what the heck? But you should do something, even if it's, if your personnel, you know, is you're quiet, you come to them later, come to the supervisor later, but you could also just simply say, oh, what's going on here? You know, this kind of thing. So I'm just going to read a part of this. We had so many examples of what people told us from their own mouths, and then we'll go to the case study. So this is racist treatment after surgery. So within the last 2 years, an Indigenous woman from a remote community has twice traveled to Lower Mainland Hospital, meaning Vancouver here, to undergo surgery for brain aneurysms. On both occasions, she experienced racist treatment from the recovery room nurses. She describes waking up, not feeling well, vomiting. She calls the nurses yelling at her across the recovery room, "You're going through withdrawal. It's all from your alcohol you people drink. You'll have to wait for your booze." She says she was subsequently moved for 3 days to different rooms where she got no nursing assistance. The same thing happened in 2019. She felt sick, was dry heaving, and the person's yelling at her, "You people drink too much." So consequently, skipping to the end, they were so hurtful and they are so fearful that she decided she'll just live with the aneurysm, whatever happens, happens kind of thing. And I actually wrote a paper quite a while ago called Tolerated Illness, which speaks to this. You'd literally rather go home and die than face this perceived and real racism. So this brings us to the case study. And then when we come back to the bigger group, I just have, I think, 3 more slides sort of wrapping it up. So this is one that, again, this Indigenous man told us, and it's in in plain sight. One evening in February 2019, a 57-year-old Indigenous man fell while walking to the bathroom in his home. It was nearly midnight, and he realized that he was badly hurt, so he called an ambulance to take him to the nearest hospital where he was x-rayed. Nurses subsequently informed the man that there was nothing wrong with him, and he had to go home. He protested, insisting he was certain he was injured, and he couldn't walk, particularly since he had left the cane he used due to a pre-existing spinal condition at home. He says 2 nurses, a male and a female, treated him poorly and made fun of him. They just thought I was a drunk. Eventually, as the argument with nurses continued, security was called, followed by the RCMP, the police. The man was ultimately arrested and taken to jail for the night. The next morning, he was released from jail, but he was still in pain and couldn't walk. The man was taken by ambulance back to the same hospital where this time he was diagnosed with 2 cracks in his pelvis. He recalls one of the same nurses commenting sarcastically, "Well, you were able to walk out of here last night." So using the information that I've given you about Indigenous people, what would you do if you saw part of this or all of this? And then I guess we will go to rooms.